Hello, wonderful staff of the Northwest Kidney Center, particularly those at our flagship unit in Kent. Welcome to the August 2022 monthly in-service. This month's topic is kidney transplantation, which is the proverbial light at the end of the tunnel for our dialysis patients. Kidney transplantation, definitely the treatment of choice for most patients with kidney failure. A successful kidney transplant improves the quality of life, reduces mortality, and is also a lot less expensive for the majority of patients when compared to maintenance dialysis. There are four objectives of today's talk. We'll review the history of kidney transplantation, discuss the transplant evaluation, address barriers to transplantation, and then finally review the rules of the waiting list for a deceased donor renal transplant. Let's begin by reviewing the history of kidney transplantation. So in 1902, the first successful experimental kidney transplant was performed at the Vienna Medical School in Austria using animals. The surgeon Emmerich Ullmann, shown in the picture there, reported the first case of a renal autotransplantation performed in the neck of a dog. That is, he removed the dog's kidney and then transplanted it back into the neck of the dog, demonstrating that kidney transplant is technically possible. As an aside, he also transplanted a dog's kidney into a goat and a pig kidney into a woman with kidney failure, but these were unsuccessful. And after that, he stopped the research in the field and devoted his time to other lines of surgical research. And then in 1909, the first kidney transplant experiments were performed in humans in France using animal kidneys. A surgeon inserted slices of rabbit kidney into a child suffering from kidney failure. The kidney initially worked well and produced a lot of urine, but then stopped working after about an hour. So the surgeon recognized that the immediate results were excellent, but the long-term results were very bad. Unfortunately, the child died about 2 weeks later. Scientists were beginning to recognize that kidney transplants were possible, but their success was limited by unknown biochemical barriers which prevented long-term kidney survival. And we now recognize these biochemical barriers as the immune system. Then in 1933, the Soviet surgeon U. Voronoi performed the first human-to-human kidney transplant. It was immediately unsuccessful, in part because he procured the kidney about 6 hours after the donor's death. He also transplanted across a major blood group mismatch. So in other words, the blood types were not compatible, and this led to hyperacute rejection of the kidney transplant. He tried 4 other times between 1933 and 1949. They all failed rapidly, and he published his results in Russian. And because of the language barrier, his experience remained unknown in the West until the 1950s. On June 17, 1950, Dr. Richard Lawler performed the first arguably successful kidney transplant. The recipient was Ruth Tucker. She's a 44-year-old woman who had polycystic kidney disease. And the kidney functioned for 53 days before it failed and ultimately had to be removed 10 months later because of the complications of rejection. Now, this transplant was conducted well before the development of immunosuppressant drugs and tissue typing, which would have helped prevent organ rejection. Now, because she still had some residual renal function in her native kidneys, Tucker lived another 5 years and then died at the age of 49 of a heart attack. On December 23, 1954, Joseph Murray and his colleagues at the Peter Bent Brigham Hospital in Boston performed the first truly successful kidney transplant from one identical twin to another. This was done without any immunosuppressive medication because, of course, the twins have the same immune system. The twins were Ronald and Richard Herrick. Richard was the recipient and Ronald was the donor. So the recipient of the transplant was Richard Herrick, and not only did he receive a successful kidney transplant, but he also met his future wife in the recovery room. Her name was Claire, and she was a nursing supervisor for the recovery room, and she volunteered for one-on-one care of Richard on that Christmas weekend because she was away from her home in Nova Scotia. She had no holiday plans. Richard and Claire later married. They had two children. One of the children became a teacher, and the other one became a nurse at a dialysis unit. And Richard lived an additional 8 years after the transplant with good health before developing problems in his new kidney that were unrelated to the surgery. Ronald donated his kidney when he was a freshman in college. He became the world's first living organ donor. He went back to school a couple of weeks later. He went on to become a math teacher in high school, junior high, and college. Interestingly, ultimately, he developed end-stage renal disease himself, and he required dialysis for 10 years prior to his death at the age of 79 in 2010. In 1964, the first deceased donor renal transplant was performed following the introduction of one of the first immunosuppressive medications, azathioprine. And since this time, there have been significant advancements in the area of immunosuppression, which have made rejection a much less likely occurrence. Okay, part two, the transplant evaluation. So how do our patients get a kidney transplant? Well, first we have to send them to a kidney transplant program for an evaluation to make sure that they are a candidate for surgery. And there are 3 transplant programs in town: the University of Washington, Virginia Mason, and Swedish. So the kidney transplant programs screen our patients for physical, psychological, and social barriers which might compromise the success of the operation. So the last thing that we want to do is give someone a kidney transplant and have it go badly, because this will leave them worse off than if they had just stayed on dialysis. And a lot of our patients have serious medical conditions or high number of comorbidities that can increase the risk of even dying, after a transplant. So it's important to make sure that they're a good candidate before putting them through surgery. One of the most important parts of the transplant evaluation is screening for cardiovascular disease. This is the #1 cause of death among dialysis patients, and significant disease typically precludes someone from receiving a kidney transplant. Testing includes an electrocardiogram or an electrical heart tracing, an echocardiogram or an ultrasound of the heart, as well as a stress test of the heart in which we see how well the heart functions during exercise or simulated exercise, as well as examine the blood supply to the heart. We also screen patients for infection because untreated infections can flourish in the setting of immunosuppression. We screen our patients for multiple infections. These include tuberculosis, oral infections such as cavities and gum disease, HIV infection. Interestingly, HIV infection was once considered a contraindication to kidney transplantation, although this is no longer the case. These patients can be successfully transplanted with careful management of the infection with antiviral medications. Hepatitis B virus needs to be treated prior to transplant, as immunosuppression can worsen the infection. In contrast, hepatitis C can be treated beforehand, although sometimes the transplant program will transplant a kidney from a hepatitis C positive donor into a patient who has hepatitis C, and then treat the hepatitis C after the transplant surgery. And this has the advantage of allowing for a hepatitis C infected kidney to be used for transplant rather than being discarded. In certain areas of the country, such as the Southwest and the Midwest, we screen for common fungal infections such as histoplasmosis and coccidiomycosis, as they can worsen after a transplant and initiation of immunosuppression. And finally, for candidates with origins outside the United States, we screen for other common infections such as strongyloidiasis, which is an intestinal parasite, and Chagas disease, which is a parasite that can sometimes affect the heart muscle and is endemic in parts of South America. Transplant candidates need to undergo a thorough evaluation for cancer before being approved for transplant. Active cancer, of course, is a contraindication to kidney transplantation because cancer, similar to infection, can flourish in the setting of immunosuppression. Now, in patients who are diagnosed with cancer prior to transplant, their cancer mortality seems to be 2 to 3 times higher compared with recipients without a history of cancer. So again, it's very important to identify cancers before the transplant if they are present. What cancers do we screen for? Well, in women, we screen for breast cancer and cervical cancer. In men, we screen for prostate cancer, and we screen for colon cancer in both men and women. If cancer is found, it needs to be treated, and patients need to be in remission for some period of time, depending on the type of malignancy, before being considered for transplant. Typically, this is 2 years. Transplant programs also evaluate patients for obesity or an elevated body mass index. It's a relative contraindication to kidney transplants, and most transplant programs require a body mass index of less than 38. Turns out that kidney transplant recipients with obesity are at increased risk for a number of adverse outcomes after a transplant. One study published in 2015 in the British Medical Journal was a meta-analysis of over 209,000 kidney transplant recipients. And they compared outcomes of the transplant among recipients with and without obesity, defined in this study as a body mass index of greater than 30. And what they found was if you had a body mass index greater than 30, obesity was associated with a 50% increase in death, a 50% increase in delay of the kidney allograft function, 17% increase risk of acute rejection, 300% increase risk of wound infection, almost a 500% increase of wound dehiscence where the wound separates, and a 150% increase risk of diabetes. So weight loss is very important to address prior to transplant. We also screen our transplant candidates for peripheral vascular disease, that is, blood vessel disease in the periphery of the artery, such as the arms and legs. Transplant kidney is placed in the pelvis and is attached to blood vessels called the iliac arteries. And if a patient has significant vascular disease or cholesterol accumulation within the wall of the blood vessels, it may not be possible to sew a kidney in place. Studies have suggested poor outcomes among transplant recipients who have peripheral vascular disease. This one study published by Snyder in the Journal of the American Society of Nephrology in 2006 found that the presence of peripheral vascular disease in a transplant patient was associated with an increased risk of amputation, allograft ischemia or the kidney transplant not receiving enough blood supply, other morbidity, and poor survival. Those with peripheral vascular disease also had an almost twofold increase in mortality following transplantation. Patel published a study in 2017, which is a retrospective cohort of 819 patients who had arterial studies within 5 years prior to kidney transplantation, and reported that those with peripheral vascular disease have a twofold increased risk of mortality and a threefold higher risk of their kidney transplant failing. Transplant candidates are also screened for underlying lung disease, and those who have significant pulmonary disease are typically disqualified for transplant. Conditions which would disqualify a patient include requiring supplemental oxygen, having uncontrolled asthma, pulmonary hypertension or elevated pressures in the pulmonary arteries, or severe chronic obstructive pulmonary disease or COPD. All potential transplant recipients should undergo a psychosocial evaluation to identify behavioral, social, and or financial issues that may influence adherence and outcomes after transplant. First, we have to make sure that patients understand the transplant process. So they have to understand the need for lifelong immunosuppression, the need for adherence to medications, as well as follow-up. It's important to do a cognitive evaluation. So basically to assess the patient's decision-making capacity, ability to provide informed consent for transplantation. Now, some patients with severe cognitive impairment may still be acceptable candidates for transplantation, provided that they have adequate caregiver support and supervised medication administration after transplant. Patients with mood, anxiety, and personality disorders should be referred to psychiatry for treatment in order to improve the success after transplantation. Patients are screened for alcohol and or substance use disorders, so these had to be addressed prior to transplantation. And if they're discovered, patients are referred to a rehabilitation program, and then we have to make sure that they remain drug and alcohol free, confirmed by random drug testing. Programs have different opinions regarding marijuana. Most centers consider marijuana use to be a contraindication to transplant. There are different reasons for this. If you smoke marijuana, you can inhale something called aspergillus, which is a fungal infection, and that's a risky thing to do when you're on immunosuppression. Transplant patients have died from fatal pulmonary aspergillosis. Also, there's a potential for drug interactions between marijuana and some of the immunosuppression medications. Patients in general should quit smoking before they receive a kidney transplant. Not all programs require this, but all the ones in Seattle do. Adherence patients prior and current adherence to medications and other recommended therapies such as dialysis needs to be assessed. And sometimes patients, just can't take their medications, and these patients make poor kidney transplant recipients. Social support. Patients should ideally have a stable support system throughout the transplant process and afterwards. And if someone doesn't have any social support, that's a contraindication to transplantation in most centers. And finally, financial support. Basically, medications, particularly the immunosuppressive medications, are expensive, and so sometimes we have to address a patient's insurance before a transplant because addressing these financial barriers after transplant can be quite difficult. Laboratory and imaging tests are routinely obtained during the transplant evaluation. They include an echocardiogram, again, an ultrasound of the heart. We talked about the cardiac stress test, which looks at the blood supply to the heart during exercise, and if that's abnormal, patients would undergo an angiogram or a left heart catheterization. We obtain a chest radiograph. In women, we arrange for a pap smear and a mammogram. All patients undergo a colonoscopy and have to see a dentist. And then there are a whole bunch of blood tests that are done, including their blood type. So blood type A or blood type B or blood type O or blood type AB. Okay, let's now discuss some of the barriers to transplantation. There are a number of absolute contraindications to transplant. These include active infection, active cancer, active substance use disorder, uncontrolled psychiatric disease, documented non-adherence with either medications or dialysis. And finally, a significantly shortened life expectancy is generally a contraindication to transplantation. So if you have a dialysis patient who has so many medical problems and they're demonstrating failure to thrive and they're probably not going to last that long, then that would be a contraindication to transplantation. Relative contraindications include older age. Now, age itself is not an absolute contraindication, but the older the patient, the shorter the life expectancy, and this may limit transplant candidacy. So if you have an 80-year-old dialysis patient, it's unlikely that they're going to live long enough to derive the benefit from a transplant that a younger patient would. Malnutrition, if a patient is all skin and bones and doesn't eat well, that person may not do well with transplant surgery. Any sort of active systemic disease like lupus or vasculitis or amyloidosis or any number of conditions that is systemic and sometimes difficult to manage is a relative contraindication to transplantation. And finally, frailty. So frailty basically is characterized by a physiologic decline. Might include features such as weight loss, fatigue, weakness, difficulty walking, low activity level. exceeding what might be expected based on age alone. And for transplant candidates who are frail, basically studies suggested an increased risk of, kidney dysfunction, increased need for hospital readmissions, longer length of hospital stay, and an increased risk of death after transplant. Okay, let's talk now about the transplant waiting list. So once candidates are approved for transplant, they are placed on a waiting list. Every year you're on the list, you get 1 point, and then kidneys are allocated to those with the greatest number of points. So the number one determinant of who receives a kidney transplant is how long you've been on the waiting list. It's therefore advantageous to get placed on the active transplant list as early as possible, even before starting dialysis. So candidates may be on the active or the inactive list. And a candidate on the active list is eligible for a transplant if a kidney is offered, whereas a candidate on the inactive list is temporarily unavailable or considered unsuitable for transplantation and cannot receive kidney transplant. So candidates are placed on the inactive list if they develop some sort of intercurrent condition like a cancer or an infection or something like that that would make transplantation inadvisable. So they're not delisted, however. They continue to gain waiting time while in inactive status. Currently, there are about 106,000 patients on the kidney transplant waiting list. Organs are allocated on a point system, mostly determined by waiting list time. Again, you get a point for every year you've been on the transplant list. Blood type is also important. It is shorter for blood type AB because someone with blood type AB can receive any kidney, an A kidney, a B kidney, or an O kidney. And that's followed by blood type A, and then blood types O and B have the longest waiting list time. So what are the demographics of the waiting list? Well, about 25% of the patients are above the age of 65 years of age. About 33% of the patients are African American, which is about 3 times the rate of the general population. 36% are Caucasian, 21% Hispanic. 60% are men and 40% are women. 50% have blood type O. 27% blood type A, 70% blood type B, and 2 to 3% have blood type AB. And finally, 38% of the patients on the transplant waiting list are diabetic. Unfortunately, many candidates for transplant die on the waiting list. The overall mortality on the waiting list is about 5% per year and 7% for diabetics on the transplant list. This seems high, although still it's a lot lower than for dialysis patients who have an annual mortality of about 20% per year. Death increases with age. About half of the deaths on the waiting list occur in patients who are on the inactive list. In short, we need more organs. And since donors are hard to come by, one of the areas of active research is a topic I addressed in an earlier in-service called xenotransplantation, or the use of non-human kidneys for transplant. Hopefully, we will have updates soon regarding the progress of this research. Most importantly, kidney transplantation should be considered the treatment of choice for most patients with end-stage renal disease. A successful kidney transplant improves quality of life, reduces mortality, and is less costly for most patients compared to maintenance dialysis. Patients should be referred for a transplant evaluation when their kidney function falls to 20%, even before they've started dialysis. We have 3 kidney transplant programs in this area: Swedish, Virginia Mason, and the University of Washington. Evaluation includes medical evaluation for problems such as cardiovascular disease, peripheral vascular disease, infections, and cancer. Patients also undergo a psychosocial assessment to look for substance abuse, compliance issues, psychiatric disorders, as well as problems with social or financial support. Absolute contraindications of transplant include active infection, active cancer, active substance use, uncontrolled psychiatric disease, and adherence problems. Relative contraindications include older age, malnutrition, active systemic disease, and frailty. The waiting list is about 4 years long for people in this country, but up to 10 years in other parts. And as I mentioned earlier, the number one determinant to receiving a kidney transplant is how long you've been on the waiting list. Patients start receiving time on the waiting list as soon as they either start dialysis or are approved for transplant, whichever comes first. Time for the monthly quiz to see how well you paid attention. Okay, question number 1. Why is kidney transplantation preferred over dialysis? Excellent. Longer life, lower morbidity, lower cost, and better quality of life. Question number 2. When was the first truly successful kidney transplant performed? Excellent. December 23rd, 1954, at the Brigham in Boston, and the recipient, Richard Herrick, received both a kidney and a wife. Next question. Name 3 contraindications, so absolute contraindications to kidney transplantation. Okay, so active infection, active cancer, active substance use, uncontrolled psychiatric disease, and adherence problems. Question number 4, is there an age cutoff for kidney transplantation? So technically no, but age greater than 75 may not be practical, particularly in the absence of a living donor. So the average waiting list time again is 4 years, and if you get approved at the age of 75, you're going to be close to 80 when you actually get offered a kidney, and sometimes people are not in the best shape after they've been on dialysis for 4 to 5 years. Last question, what is the number one determinant to receiving a deceased donor renal transplant? That's right. How long you've been on the waiting list. So that's why we have to refer our patients early for kidney transplant evaluation. Well, this concludes the August 2022 monthly in-service for the Kent unit of the Northwest Kidney Center. Thank you so much for listening, and thank you so much for providing such excellent care to our patients and making the Kent Northwest Kidney Center the special place that it is. This is Andy Berkenbrough signing out until next month. Goodbye.